Thanks for joining us this morning for our professional development program looking at sleep, sleeping well and improving sleep for our clients. Your presenters today are Dr Simon Frenkel, who's waiting in the wings. Simon is a sleep specialist and he can fill you in on his role, but Simon's been supporting us for a couple of years now in running programs around better understanding sleep issues and how we might help our clients in that regard. And I'm your other co-facilitator today. I'll also be monitoring the questions. My background is occupational therapy. I've worked here at MS for over 13 years in a role as a hands-on occupational therapist and then more recently coordinating the education programs. So I've got a fair amount of experience with helping people manage fatigue and sleep. So as we start our program, we acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. Today, our learning objectives are to identify some common sleep issues, particularly for people with multiple sclerosis, to better understand the causes for our clients with MS, and then to explore some management principles. Also to develop a bit of a strategy for assisting our clients when they have poor sleep. And some of that is to do with what we can manage as practitioners and when we need to refer on. And therefore, hopefully, by the end of the session, to be a bit more confident in working with our clients, particularly around sleep concerns. We know that approximately 50% of people with multiple sclerosis report ongoing sleep disturbances. And it was interesting, there was some research done a couple of years ago in America it was a 10-page questionnaire that went out to almost 3,000 people with MS, and over a third screened positive for obstructive sleep apnea, and yet only 4% reported having been diagnosed by a doctor with that condition, so very much underreported. Another one was 31% reported insomnia, but only 10% had been diagnosed with it. And 37% had reported restless leg syndrome, but only 12% had a formal diagnosis. So we do recognise that it's a very underreported issue and often something we forget to ask about. We had some students with us a few years ago and they did an informal survey of our clients through ACT New South Wales Victoria, and 81% of people came back saying they had a problem with sleeping well. So I think it's huge, and I do think we're only beginning to give it its proper attention. The survey that the students did, people were reporting things like needing to go to the toilet, feeling too hot, being worried or stressed, muscle spasms. So some things that were very much symptom related, other things that were perhaps more emotional reactions, might have more complex reasons for why they're disturbing their sleep. But some are pretty obvious symptom issues that maybe could be addressed. And then there was the ordinary sleep issues as well, and that's perhaps one of the complexities, that we've got this overlay of totally ordinary sleep disturbances that we all experience, layered with some of the issues that come because of having the disease process of MS occurring at the same time, let alone other things that might be happening too. This is a slide that we often refer to in regard to symptoms that people with MS might experience, and you'd be aware of all of these symptoms in your client group as well. There's a whole range of symptoms depending where the disease activity is occurring, what symptoms people might experience. But 80% of people report fatigue as one of their top 3 symptoms. So we know that fatigue is a huge issue for people with MS, and we perhaps then need to start thinking about the impact that sleep issues have on that fatigue. So particularly for the OTs in the group who might have a bit of a focus around managing fatigue, we've got to remember to ask about sleep, because we might be able to deal with some of the sleep issues before we go on and deal with some of the fatigue issues you know, your best laid plan around managing fatigue is going to be undermined by any sleep issues that the person is experiencing. So we need to remember to address that. And like you'd be aware already, the interplay of symptoms for people with MS causes the disabling impact. So the person who has some degree of balance issues, maybe they're managing okay, but they're working harder to retain their balance, so their fatigue's worse. Or they're working so hard on their balance that they have trouble getting to the toilet on time when they have a twitchy MS bladder. That means they have urgency or frequency. You know, it's all this interplay of symptoms that we need to be mindful of, and particularly why, for us here at MS, sleep has become much more of an issue to be discussed rather than just the sort of the surface issue of fatigue. I hope that's a good explanation of how this all came about. It's kind of, this is a diagram that we've used a couple of times in a couple of poster presentations where, you know, fatigue's in there, but really there's so much interplay between all the other symptoms on fatigue, and poor sleep is just so much needs to be highlighted about sleep when it's interacting with all the other symptoms that a person is experiencing. Caused by, causing, you know, where do we stop and start? I guess that's why they came up with the circle diagram. And we all recognise that sleep is important. It's certainly important. This quote, improving sleep quality will improve quality of life for people with MS as it provides improvement in physical and mental well-being. Getting a good night's sleep might not cure or even improve the neurological damage of MS, but it would certainly help people face it with a better outlook and give them a better chance at a fuller life. Rest and sleep are necessary for conserving energy, restoring your mind and providing energy to engage in daily activities. It's also important for improving memory and concentration. During sleep, the body detoxes and repairs cellular damage. Growth hormones are produced, as well as the factor that stimulates the growth of red blood cells. Damaged tissues are healed at a greater rate while sleeping. So lots of research, lots of evidence to support the importance of getting a good night's sleep. And when we ask our clients what do they experience when they have a lack of sleep, it's the same as we all recognise. Yes, increases fatigue, lessens our ability to participate in activities, can impact mood, that's that grumpy syndrome, amplifies any problems they might have with memory and concentration. So already putting people on the back foot rather than, you know, being able to proactively manage any issues they might experience around memory problems, concentration, multitasking, problem solving, all that kind of stuff. Decreases alertness and a person's capacity to problem solve. And so we want to avoid some of this stuff. Lost my mouse. So this is a great opportunity to segue to Simon, who'll be able to give us the background as to some of the issues people with MS experience. So I'm just going to hand over control to him and turn off my camera so you don't need to see me anymore.
Good morning, everyone. Can you hear me?
We can hear you, Simon. Thank you. And we can see your slides.
Right. All right. Fantastic. All right. Thanks for the introduction. Yeah, as Andrew said, I've been doing this the last few years, and I find it a particularly sort of interesting and unfortunately difficult topic. So it's nice to sort of be back speaking about it again. Just a disclaimer at the outset that I'm recovering from both jet lag and man flu at the moment. So if I make no sense, that those might be the reasons. I would like to tell you that this is an easy topic and that I'm going to be able to explain it all, but as Andrew already alluded to, it is extremely complex. Sleep itself is a complex and difficult area, and I don't need to be telling you guys that multiple sclerosis is the same, and so when you look at an overlap between the two, you know, you're treading some pretty choppy waters. I'm a respiratory and sleep physician. I've got a particular interest in sleep disorders that are not just the garden variety, snoring and sleep apnea, which a lot of sleep physicians are interested in. And so these are what we call the sort of the non-respiratory sleep disorders. And MS and its manifestations in sleep sort of come within that umbrella. So what I'd like to do today is actually spend quite a lot of the talk just explaining to you about what sort of normal sleep actually is, because MS can impact on sleep in so many different ways that I think the better your understanding of sort of basic healthy sleep is, might give you sort of better tools and I guess a bit of confidence in trying to work out how someone's particular manifestations of MS might be impacting on their sleep. So a lot of the talks are actually going to be on that, and then sort of towards the end we'll come more towards how MS specifically can affect sleep, and then finish up just looking a bit at fatigue and how we might be able to manage that. So sleep, this is actually from a very large tome textbook of sleep medicine, and a quote by a Scottish physician in the 1800s by the name of Robert Knish, who described sleep as being an intermediate state between wakefulness and death, wakefulness being regarded as the active state of all animal and intellectual functions, and death as that of their total suspension. And sort of what we've done over the years is really refine that definition, but we've not really yet got a single definition that completely encapsulates what actually sleep is. And so just depending on the viewpoint that you're looking at, there are different definitions. So from an experiential point of view, people will define it as a state of being, unaware of your external environment. To someone who's watching another person asleep, they'll describe them as being quiet, with their eyes closed and generally unresponsive. But really, most of what we do as clinicians is describe sleep as a neurophysiological state. We do an EEG where essentially, on the surface of someone's scalp, we're measuring electrical activity of the EEG. And what we see in sleep is various types of slowing of that EEG, or the electrical activity that define the various depths of sleep that we go through during the night. But obviously sleep is more than that, and it serves a very important functional process. It's homeostatic. It restores our biology to sort of baseline each day. There's some very interesting data about that's emerging now that people have been doing for the last few decades, showing that intact sleep is really important for various aspects of memory handling, memory processing, laying down memories, stripping away emotional content from memories, which is really important for people with post-traumatic stress disorder, and also it's obviously the home of dreams. So in terms of the experience of sleep, sleep is not a smooth thing that occurs in a consistent way through the night, and in fact up to 30% of normal sleep is actually characterised by some sort of awareness of things around us. So it's not always deep and completely unresponsive to the outside world. The definitions of sleep and how sleep actually works have evolved over time, and when you read historical descriptions of sleep, and some of these sort of date back to ancient times, you get very consistent across the ages and across various sort of cultural societies, this description of what's called segmented sleep, where people would usually sleep not long after sunset, very deeply for a few hours, and then in the middle of the night they'd have a period of wakefulness. And this is not them just lying in bed awake. This is actually being awake and active. They're cleaning the house, they're praying, they're socialising, and then they'll go back for what's called second sleep, where it's a bit more of a dozy sleep for a couple of hours until sunrise. And it wasn't until industrialisation that this concept of 8 hours of sleep emerged, and in many ways it's been a bit of a counterproductive concept, in that a lot of people don't actually require 8 hours, and it sort of feeds into some of the problems that our insomnia patients experience. So the way that sleep works across the night, and I've alluded to this already, is that the depth of sleep varies. Can you see my cursor floating around here?
Yes, we can.
Yeah, you can. Good. Okay. So the depth of sleep, sleep is described as either being REM, the rapid eye movement sleep, or non-REM. And the non-REM stages go from stages 1 through 4, getting increasingly deeper as the numbers get higher. So you have this deep stage 3 and 4 sleep predominating in the first half of the night. That's the really deep sleep where if you get a few hours of sleep just for, for 1 or 2 nights in a row, you actually don't feel too bad the next day, because that's the recharging of the battery sleep. What happens as you get closer to the morning is that sleep becomes lighter and you have more of these black areas. These are the blocks of REM sleep. So REM sleep is actually quite a light and easily to rouse from sleep that happens with greater frequency and of increasing duration the closer you get to the morning. So that's why, when the rubbish truck rumbles past at 5 in the morning, you're more likely to hear it than if, the hoon drives past at 2 in the morning, for an example. So sleep across the night is not necessarily consistent. Across the lifespan, there are changes that occur during sleep, with aging in particular. And what we can see here is, so this abbreviation WASO is wakefulness after sleep onset. So this is how much time you're spending awake after you initially fall asleep at the beginning of the night. And particularly as people get considerably older, they're spending more time awake during the night. The proportions of REM sleep generally don't change very much as people get older, but this slow wave, the very deep non-REM sleep, does actually diminish. So as people get older, their sleep becomes lighter and a bit more fragmented. But really that's not until, sort of the 7th and 8th decades. I've alluded to this before, but this shows the effect to which the labour movement has affected sleep. And you may recognise this as the Monument to the Workers, which is outside Trades Hall in Carlton. And what you can see up here is the 888. So the labour movement actually had its home in Victoria. So this Monument to the Workers was the initiation of this 8 hours sleep, 8 hours recreation, 8 hours rest. So this is where it all started, 8 hours sleep. But really where society has moved since then is that we favour short sleep. It's seen as a positive trait. This is a picture from the Biggest Loser a few years ago. T-shirts that are wearing saying sleep is for the weak. What it should really say is that sleep deprivation contributes to obesity, but that's not a very popular line to be talking about. This is an article from The Age back in 2009 where Therese Rain was saying how fantastic it was that Kevin Rudd, her husband, only slept for 3 or 4 hours a night. Might have explained some of his moodiness. And history is sort of dotted with, and I've got inverted brackets here, great people who sleep less. Many of these are not great. Margaret Thatcher, for example, was a normal sleeper until she became PM, and then sort of learned to only sleep 4 hours a night. Edison, who's in the photo here, thought that with his development of the light bulb that the need for sleep would largely be replaced. It was widely known, however, that he actually had a bed in his laboratory and spent most of the day sleeping. So, sort of this concept of not needing much sleep is something that's really been present for quite some time. How much sleep do we actually get? I find this sort of stuff really interesting. So this is from the jawbone. You've probably all got patients who are wearing these wrist monitoring devices that tell them how many steps they're walking and what their heart rate is and how many calories they're burning. But they also measure sleep, and this is from the data of probably a couple of million patients across the world wearing a jawbone. The way that it measures sleep is basically by showing absence of movement. And so what we're getting is very low fidelity data, but on enormous numbers of people. And what the pattern is very interesting is that the sleep is fairly consistent across the world. In Melbourne, we like our sleep. In the cohort that they analysed, we're sort of nearly averaging approximately 7 hours sleep versus those in Tokyo who are under 6 hours. Muscovites like going to bed late and getting up late, whereas the Brisbaneites are the opposite. They get to bed early and rise early. So I think this is sort of an interesting way of looking at sleep, and certainly with my patients who who often bring downloads of this. It's an interesting way of engaging with patients about measuring sleep. But what we're seeing is that, even in Melbourne, we're not getting a lot of sleep. So how does that fit? How much sleep should we actually be getting? Now, until recently, we didn't really know the answer to that. There had been sort of motherhood statements that you need 8 hours a night. The American Academy of Sleep Medicine last year did a very exhaustive analysis of over 5,000 scientific papers to try and come up with a formal recommendation. And what they came up with was that healthy adults should sleep for a minimum of 7 hours per night on a regular basis to promote optimal health. They found that consistently sleeping less than 7 hours was associated with adverse health outcomes, including mood disorders such as depression, cardiovascular disease, obesity and pain. They were a little bit more cagey about what long sleep actually meant in terms of whether that was associated with adverse health outcomes. They thought that it was appropriate for certainly younger people who need that much sleep, people who are recovering from periods of sleep loss or insufficient sleep, or, in those with illnesses. And so, particularly as it refers to patients with MS, this 7 hours should probably be seen as, really an absolute minimum for a lot of them, and, some of them may well require 9 hours or more. So what drives sleep and wake? What's emerging, not surprisingly, is a fairly complex picture of overlapping processes, and there are three main processes that we look at to be in sync in terms of driving sleep and wake to occur at regular and predictable times. And over the next few slides I'm going to show these, but essentially we're talking about what's called the sleep homeostat, process S, which is basically just how long you've been asleep for, how long you've been awake for, how tired you are. There's process C, which is our circadian or intrinsic biological rhythm, and what's increasingly become important is a concept of hyperarousal, how anxious or sort of wired someone is, and that certainly has very significant impacts on sleep, particularly people with anxiety disorders and insomnia. So what this graphic shows is how the sleep homeostat works. So what we've got across this axis here is the time across the day, and on this axis here is the sleep drive, how sleepy you are. You wake up in the morning and your sleep, this is talking about healthy people obviously, your sleep drive is very low. The longer that you are awake for, the more sleepy you become, till it gets to a point where for the average person, and I've just sort of kept the numbers simple here, after about 16 hours you have accumulated enough sleep debt, enough sleep drive that you must go to sleep. And what happens through the night in sort of a fairly linear fashion is that you pay off that sleep debt, the sleep drive diminishes, and then you reset and you're back to the same the next day. So you're roughly needing about 1 hour of sleep for every 2 hours that you're awake. But not everyone's the same. So there are some people who do actually require less sleep. There's a particular gene mutation called the DEC2 gene mutation, where these very fortunate people who have this gene really only need 5 or 6 hours sleep to feel absolutely fantastic the next day. And we're not sure why that is. Do they accumulate sleep drive very slowly when they're awake, or do they burn it off very quickly when they're asleep? We don't know, but these lucky people don't need very much sleep at all. So how does hyperarousal work? So the way of thinking about hyperarousal is how sort of anxious or wired someone is. So what's emerged there is someone with a low level of hyperarousal. So they accumulate their sleep debt during the day, and as they're paying it off during the night, the hyperarousal or that drive to being awake doesn't really rear its head until, just prior to them being awake. If you've got someone who is highly anxious, either due to an underlying anxiety disorder, a sleep disturbance, insomnia, anxiety about sleep, their degree of hyperarousal is much higher, and so what happens is they'll be able to initiate sleep okay at the beginning of the night because their drive to sleep, because they're so sleepy, will be quite high, but after the first couple of hours of very deep sleep, they've paid off that sleep debt, and because their degree of hyperarousal is so high, it'll start interfering with their sleep, and these people will sort of, the ones who will describe to you, look, I fall asleep at 10:30 at night, fine, and I wake up at 2 o'clock to go to the toilet, and I'm wide awake, and my mind's racing, and I can't switch it off. So that's a really important concept in dealing with people with insomnia. What I've not shown in any of these slides is, because it's complex in terms of how it interfaces with it all, is the circadian rhythm. So this is the normal biological rhythm that works in concert with these other factors to keep us awake when we need to be and keep us asleep when we need to be. And in most people, it's nicely in sync. In someone like me who's jet lagged, there is there's a discrepancy between what my internal clock timing is, which is somewhere between here in the US at the moment, and what the external environmental cues are, where it's 10:30 in the morning and I'm in Melbourne. So jet lag is just a disturbance of that circadian rhythm. So moving on to what the symptoms of a sleep disorder are, and I will eventually get to MS, but I just thought that it's very important to sort of get these basic fundamentals tucked away first. The symptoms of a sleep disorder can present in a number of different ways. Patients may complain to us of difficulties initiating sleep, so I can't get to sleep, difficulties maintaining sleep, that they can't sleep enough, or that they're not sleeping for long enough. They might describe their sleep as being non-restorative or unrefreshing. Or they might describe the daytime correlates of poor quality sleep. And these are difficult to describe because we like to put things in very clean silos. Is someone fatigued? Do they just not have enough energy? Are they tired? Do they not feel awake enough? Or are they sleepy? Do they have an increased propensity to fall asleep, particularly during passive situations? And whilst we like to sort of compartmentalise things and think about them as being mutually exclusive concepts, in the real world they're sort of not. And patients will often describe to us combinations of these disturbances of daytime function. They might also describe other symptoms of a sleep disorder. They might complain of restless legs, a really uncomfortable sensation and urge to move the legs during periods of rest and inactivity, particularly towards the end of the day when they're in bed. There might be abnormal behaviours during sleep, sleepwalking, sleep talking, acting out dream content. It can just be more garden variety. They could complain of snoring or apneas, their bed partner reporting that they stop breathing when they're asleep. Or they might be keeping unusual sleep times, not feeling sleepy until, the very early hours of the morning and not waking until lunchtime. And those unusual sleep times can sometimes indicate an underlying disturbance of the circadian or biological rhythm. So, as Andrea already alluded to, sleep disorders are much more common in people with MS, and I think she quoted 50%, and I agree with that and probably raise that. I think that if we asked, we would see that they're common. Fatigue is almost universal, and with these types of conditions, and we know that in Parkinson's disease, for example, when they've done sort of population surveys in those patients, most of them, as troubling as the motor symptoms are, most of them report their biggest problems as being with sleep. So it's something we need to sort of have a bit of confidence with and be, I guess, proactive about asking, people about disturbances with their sleep. One of the because it's got such protein manifestations, the temptation is once someone's got a diagnosis of MS, everything is then due to the MS, and they can sometimes just get stuff that's completely unrelated. So I think we sort of just need to keep it a bit broad as well in these patients. So why my patients with MS have sleep complaints? Well, it could be due to just specific disease manifestations. They might be getting problems with, nocturnal spasms, continence problems, and I think that you would sort of all be pretty confident in identifying those particular issues. We know that MS can specifically cause sleep disorders depending on where plaques are sitting within the central nervous system. So restless leg syndrome that I mentioned a couple of minutes ago, the uncomfortable urge to move, can actually be caused by plaques in MS. Narcolepsy, a disorder of excessive sleepiness, can also be caused by plaques just sitting in the wrong part of the brainstem. Mood disorders, and this is where it starts getting really tricky, are obviously very common in MS. They're common in people with sleep disturbances, and the overlap between the symptom descriptions is really big, and so it's often hard trying to work out the extent to which the mood disturbance is either the cause or the effect of the sleep disorder or even of the MS. So, I think you can start appreciating now, that slide that Andrea showed where everything sort of just loops around in a circle, makes management of these types of patients tricky, and also means that it probably needs to be multidisciplinary. So it's not just one person who's responsible for fixing it. It often takes a few of us, collaborating with the patient to try and get it right. And as I've mentioned here at the bottom, unfortunately it's often a combination of all of the above, and the degrees to which each of these might be active at a particular time varies. The reason I've put this slide up, this is a slide that was published about 10 years ago showing the really complex circuitry that is involved in the brain to drive wakefulness and sleep. And I guess the things I wanted to raise are, firstly, that you put plaques on any of these areas in the brain, and it might actually affect the way that people either experience wakefulness or sleep. But a lot of the chemical transmitters that are affected, that are important in driving sleep and wake, are actually affected by medications that we use to treat mood disorders and anxiety disorders, and that's why these things can also have an impact on wake and sleep. So moving on to insomnia now, and the reason I've chosen insomnia in particular is because I think that for various reasons a lot of people in MS will experience insomnia. It's described broadly as a difficulty either initiating or maintaining sleep that's associated with some sort of an impairment in daytime function. Why might someone with MS get insomnia? Okay, well, it could just be, disease manifestations, the spasms, incontinence, pain, that sort of stuff. They might have a mood disorder. The MS might have manifestations during the daytime that is causing poor sleep hygiene or interfering with their scheduling of sleep. The psychophysiological, there could be anxiety issues. And I think because of all these complexities, it's best to think of insomnia in MS as not being due to a specific thing, but being what I call sort of comorbid. There are a number of things that are impacting on the insomnia, and each of them need to be dealt with almost in an independent sense, as well as sort of globally, to improve the patient's outcome longer term. So, how do we treat insomnia? Well, it's very important to, I guess, try and identify what the underlying factors might be and treat those specifically. With MS, the specific, disease manifestations. The cornerstone of treatment for insomnia in general, though, is something we call cognitive behavioural therapy. So cognitive behavioural therapy is a well researched and respected psychological technique that is used for mood disorders, it's used for anxiety, and there's extensive research of a specific variety of cognitive behavioural therapy specifically directed at insomnia, and it is the recommended first-line treatment for patients with insomnia. And whilst the initial trials of cognitive behavioural therapy were done on people with just what we call primary insomnia, so just insomnia in the absence of any other medical disorders, what we've seen over recent years is that when they've administered this to people with this, in inverted commas, comorbid insomnia, so people with insomnia in the context of suboptimally treated depression or people with insomnia in the context of fibromyalgia, is that it tends to work for the insomnia regardless of what the cause of it is. So what, and I'll come to it in a bit more detail in a couple of slides, but what it essentially does is it's a structured course that's usually run by psychologists, although as allied health practitioners and as a clinician myself, there's bits of this that we can actually do ourselves, but it's essentially a structured course that looks at the behavioural factors which are contributing to insomnia, and also looking at some of the cognitive aspects as well. And I guess the cognitive parts is where the psychologist becomes a bit more helpful. And usually the courses run there, for sort of 4 to 6 weeks, with weekly visits, and there is even emerging data, and in our funding poor environment, this is a bit exciting that even in a group setting, they've done sort of group CBT and shown that to be effective. And I'll come back to sort of the various components of the CBT in a moment. But before I do that, I'll just sort of in passing mention sleep-promoting medication. This is used extensively, so sleeping tablets, benzodiazepines or related drugs like temazepam, Imovane, Stilnox, melatonin, which is a naturally occurring sleep-promoting chemical in the brain. Look, these can be helpful. I think that, and particularly in people with comorbid insomnia, when used carefully, I don't necessarily have a say-no attitude to these. And there certainly is a bit of emerging data that when used in conjunction with cognitive behavioural therapy, it improves longer-term outcomes. So, I think that they certainly can be used in the right environment. I know this is a terrible slide and it's probably doesn't transmit very well, but one of the things that we look at initially in cognitive behavioural therapy, one of the first sessions is firstly providing patients with sleep education. Right? They need to sort of understand, in the same way that hopefully you guys do now, about how sleep works, because it means that once we start intervening with them and giving them advice that sounds to them a bit counterintuitive, if they understand what we're getting at and why we're doing it, it does make it a bit easier for them to engage in treatment. So sleep hygiene really refers to sort of the habits and behaviours around sleep, and a lot of it's sort of just lifestyle stuff. Having a regular wake time every day, because a regular wake time gives, particularly with light exposure in the morning, gives very clear signals to the circadian system about what we want the timing to be. Regular exercise or physical activity, particularly in the first half of the day, restricting sleep for bed, which I'll sort of come to in a moment, making sure that the bed is comfortable, the bedroom environment is conducive to sleep, regular meals, not eating too closely, before you go to bed, not consuming caffeine in the second half of the day, alcohol, and even you're sort of cutting down smoking. So none of this is sort of rocket science, but, you'd be surprised in how many people with insomnia are sort of, having a couple of cups of tea of an evening, and I think it largely stems from the fact that people don't realise how much caffeine there is in a cup of tea, and it's almost the same as there is in coffee. So, it's rarely the only thing that's contributing to insomnia, but it's often something that can be addressed. The next things that we do are concepts of what's called stimulus control and sleep restriction. So, stimulus control is dealing with the fact that a lot of people with insomnia, because they're spending so many hours in bed awake, bed and even them seeing their bedroom generates an enormous amount of anxiety. And so what stimulus control tries to do is dissociate those conditions, more strongly associate bed with sleep. Because a lot of people with insomnia will spend many more hours in bed than are actually required for sleep. And so the concepts that we deal with stimulus control is basically saying that the only things that you should be doing in bed are sleeping and intercourse, and you should only be sleeping in bed. So really just at a psychological level, very tightly associating bed with sleep and only sleep. And so we tell them, and you know, this is often a bit difficult to do, but basically, you know, if it's taking, without clock watching, if it's taking more than about 20 or 30 minutes to get off to sleep, just get out of bed, do something relaxing, you know, such as reading or a Sudoku puzzle or listening to some music until your eyes start getting heavy again, and then go back into bed. And, you know, this is often where the cognitive therapy starts coming in, and where, you know, sometimes you need a psychologist because, you know, doing that is difficult for patients, and it does take a bit of, you know, sort of cognitive restructuring and dealing with some of the negative perceptions and expectations that often people with chronic insomnia have developed. So that's where the cognitive therapy starts getting folded into some of this treatment. But this type of advice, you know, I often think is a bit of an overlap between the behavioural aspects of insomnia treatment and the cognitive stuff, and this is sort of stuff that I'm quite happy to advise my patients to do. There's then the concept of sleep restriction, which is a terrible name, because telling someone who doesn't think that they're sleeping well that you're going to be restricting their sleep just you know, turns the anxiety levels up to 11. But really what it is time in bed restriction. You know, as I've already alluded to, a lot of these people are spending more time in bed to try and chase sleep, and invariably it compounds the problem. And the way I describe this to patients is thinking about it in extremes, in that what we're trying to do with sleep restriction is very closely match the time that they're spending in bed for the time that's actually required for sleep. Right? So if you take the average, let's say 8-hour sleeper, and you force them to spend 16 hours a day in bed. So what's going to happen is they're still only going to get 8 hours of sleep. It'll either be a block of 8 hours and then they're going to spend the next 8 hours completely awake, or more likely the sleep's going to be a bit patchy, so they'll get a couple of hours here, they'll, you know, be awake for a little while, they'll, you know, sleep a bit light over here for a bit, but, you know, the sleep will be extremely disturbed. The other extreme is if we take the 8-hour sleeper and we only allow them 5 hours per night in bed. What that insomniac will come back, you know, within a few days of saying is, look, I'm spending every minute of those 5 hours of sleep, I'm absolutely exhausted during the day. And so what we do usually with sleep diaries, where patients are able to you know, record visually on a grid how many hours they're sleeping at night, is basically prescribe a time in bed schedule. So if I have an insomnia patient who is recording, you know, even in a patchy way, for example, 7 hours of total sleep per 24 hours, I will then work with them to provide them initially a 7.5 hour window of time that they can spend in bed, and we can negotiate what you know, times that window falls within, and every 3 or 4 days can either tighten it a bit more if need to, or relax it a bit more if they're finding they're getting excessively sleepy. But that's sort of conceptually how the sleep restriction process works. But really a lot of these patients require cognitive therapy, and that's best administered by a psychologist, and there are trained sleep psychologists who can actually do this very well. Hyperarousal, I've mentioned already, is a very common concept in insomnia, people feeling very anxious either just in general or about sleep in particular, and one of the aspects of cognitive behavioural therapy is to reduce their hyperarousal, and where there's a lot of really good data now about using mindfulness-based stress reduction strategies, which I'm sure a few of you have already heard about, to improve both just general anxiety, well-being, and also insomnia. So this is something that we're using in conjunction with our psychologists. And finally, just up to my last couple of slides, just I guess looking at fatigue. You know, as I said before, almost universal in people with MS. You know, the reasons why people are fatigued are really poorly understood. And I think the approach to fatigue really needs to be individualised, you know, for each patient with MS. And I guess from a sleep point of view, just to see whether there might be any sleep disturbances that could be that could be contributing to it. So in the patients who you're seeing with fatigue, to really be sort of drilling down and just asking them about, about their sleep. And I guess you don't even really need sort of specific questions, just something broad, tell me about your sleep. And it's a really open-ended question that just sort of invites a discussion. And if their sleep's brilliant, it'll be pretty obvious, first up that it's going to be. But if there are problems, they'll tell you what those are, and I guess it just it opens the dialogue. Not only about sleep, I think it's important to measure sort of daytime activity, and a lot of us looking at sleepiness and fatigue often don't do that. My insomnia or depressed patients, often are moving just from bed to the couch and aren't very active during the day, and so with that limited activity, they're not going to be as tired coming to the back end of the day as you would otherwise expect. Are they napping during the day, which might be interfering with their sleep at night? It's tricky, but I think the consideration of a comorbid mood disorder needs to be considered, and GPs or specialists will often be doing blood tests just to make sure we're not missing something treatable like anemia or problems with their thyroid, and certainly when I see these patients, I have a very low threshold to doing a sleep study just to sort of measure what their sleep actually looks like. How can it be treated? Well, we don't have a fantastic answer for that. I mean, obviously making sure that their disease is treated as best possible, that we've optimised their sleep, that we're doing the best that we can to maintain as much physical activity as possible during the day. I've used an exercise physiologist for some of my, not necessarily MS patients, but other patients to promote some degree of daytime activity. And just some, things that will maintain a robust circadian rhythm, just giving very clear signals to the internal clock through light exposure in the morning, light restriction in the evening, and having sort of regular sleep and wake times. And as far as medication goes, there's conflicting data. I know that neurologists historically use a drug called amantadine, for which there's a bit of data. There also is emerging data for a drug that we use called modafinil, which is a wake-promoting medication that acts on the dopamine and noradrenaline receptors in the brain to promote wakefulness. And there have been a couple of large trials, or larger trials of patients, of treating it in patients with MS, one of which showed a positive result, the other which showed no significant impact. In my patients who I see with significant MS related fatigue in whom no other cause is identified, I do give them the option of self-funding a trial of this, and my personal experience with it has been, I guess, what the clinical trial experience has been. Some do well and some don't, but those who do well, it really has had sort of quite a significant impact. And because it's not on the PBS for that reason, it costs about $3.50 a tablet, and usually they can get by with 1 or 2 tablets a day. So, for those who do well with it, I sometimes justify it in terms of it being not much more than a cup of coffee or 2 a day. So, hopefully I've given you a bit of understanding about how sleep works, how sleep doesn't work, and open up the real can of worms about how sleep and MS may, and probably are very, sort of much coexistent, and I guess how we need to be working together as a team to optimise the outcome for our patients in this regard. So I think that was all I had to say. It is. So I'm happy to, I don't know if you want some questions, Andrea, or
yeah, that's fabulous, Simon.
Clarification.
I would encourage people to type in their questions. No one has put in any questions at the moment, so now's your opportunity for those people online to get their questions in. It'd be great to spend another little bit of time with everyone that's online. I'm happy to go through. I've got a set of slides that sort of explain a bit of the process that we do, exactly as Simon was explaining, how we progress with people through exploring what the issues are, and a couple of tools that we thought would be helpful for folk in their practice. But now's our opportunity. I'm not expecting Simon to stay for all of that time, so if you've got a question specifically for Simon, And I'd probably also say, Simon, if people think of their question after, I'm happy to pass it on to you. I'm sure you'd be happy to follow it up afterwards as well.
Yep.
Yeah.
Yep, sure.
Cool. So unless someone's madly typing, I haven't got questions coming in. I thought what you presented was fabulous, so that's probably why there aren't questions, because you've been really clear and it was a great presentation. I'm very, very thankful to you for the time and effort you've put into that. Is it okay if we get a copy of the slides to send out to everyone to review?
Yeah, I can do that, sure.
Yeah, cool.
Yeah, I'll email them through to you.
We'll put that into a pack of information. So thank you, Simon, for your time and for your ongoing support to these programs. It's really appreciated.